Imagine sending a text message down a frayed wire. The message arrives late, garbled, or never at all. In the human body, nerve signals travel down wires inside the brain and spinal cord. Multiple sclerosis, or MS, damages the insulating sheath around those nerves. The result: interruptions in the brain's communication with the body. Multiple sclerosis is an immune-mediated disease of the central nervous system, the brain, spinal cord, and optic nerves that leads to inflammation, loss of myelin, and sometimes direct nerve damage. It most often starts in young adulthood and affects more women than men. Meet Anna, a 23-year-old university student. One morning she wakes with blurred vision in one eye and strange tingling in her left hand. At first she thinks it's stress, but the symptoms don't fully go away. These early focal neurological symptoms are typical ways multiple sclerosis can first present. Doctors call one isolated event like Anna's a clinically isolated syndrome, an early warning sign that further evaluation is needed. Diagnosing MS is a careful process. Modern diagnostic criteria combine clinical history, MRI evidence of lesions in time and space, and supportive tests like cerebrospinal fluid analysis. In 2024, the McDonald criteria were revised to give clinicians a more flexible framework for integrating MRI and clinical findings. MRI is the most powerful tool. It shows inflammatory lesions in characteristic locations around the ventricles, in the spinal cord, or the optic nerve. A lab test of spinal fluid may show markers of immune activation that support the diagnosis. At the biological level, MS involves immune cells that target myelin, the fatty layer that insulates nerve fibers. Loss of myelin slows or blocks electrical impulses. Repeated attacks can injure the underlying nerve fiber itself, leading to lasting disability. Clinically, MS is described in several patterns. The commonest is relapsing remitting MS, clear attacks followed by partial or full recovery. Some people later accumulate disability without clear relapses, called secondary progressive MS. A minority have progressive disease from the start, primary progressive MS. Individual trajectories are variable and influenced by age, sex, and treatment. Today, there is no cure for MS, but we have powerful disease-modifying therapies, DMTs, that reduce relapses, limit new inflammatory lesions on MRI, and delay disability progression when used early and consistently. Treatments fall into three groups: acute relapse therapy, disease-modifying therapy, and symptomatic or rehabilitative care. Acute relapses are often treated with short courses of corticosteroids. DMTs act on the immune system in different ways. Some are injectables, some oral pills, and some are infusions, chosen based on disease activity and safety considerations. For example, regulatory safety agencies recently updated labels for some older MS medicines when new safety data appeared. Clinicians and patients must weigh benefits and risks together. Beyond DMTs, symptom control and rehabilitation matter. Physical therapy, occupational therapy, cognitive rehabilitation, and management of fatigue, spasticity, pain, bladder dysfunction, and mood all improve functioning and quality of life. Research now aims not only to block inflammation but also to repair damage. New strategies focus on remyelination, encouraging the brain to rebuild myelin, and on neuroprotection to preserve nerve cells. Early clinical trials and large data sets are helping reclassify disease courses and personalize therapy. Anna's MRI showed lesions consistent with MS. After confirmatory tests and a careful discussion of risks and benefits, she and her neurologist started a disease-modifying therapy. Over time, regular MRI checks and symptom-focused rehabilitation helped her stay active at university. Her story reminds us: early diagnosis, evidence-based treatment, and holistic care change outcomes for many people with MS. 3 key points to remember. 1. MS is an immune-mediated disease of the central nervous system that damages myelin and sometimes nerves. 2. Modern diagnosis relies on MRI plus clinical assessment, guided by updated criteria. 3. While there's no cure yet, disease-modifying therapies and comprehensive care reduce relapses and preserve function. Continued research offers hope for repair and personalized treatment. Multiple sclerosis reminds us how intricate and fragile our nervous system really is. From the molecular world inside our cells to the clinical discoveries shaping modern medicine, biology connects it all. If you love exploring how science works in the lab and in life, don't forget to like, share, and subscribe to Biolab TV, your window into the world of biology and lab techniques.